Good afternoon, everybody. Welcome. My name is Borshika Rabin. I'm an assistant professor at the Department of Family Medicine and Public Health, and I'm also affiliated with the San Diego VA. And I would like to welcome you on behalf of our planning committee for the Dissemination and Implementation Research Summit. Some of you were able to attend our event yesterday and or today. Some of you were not part of the process, but we are really happy that you were able to come for this presentation. This is our closing event for the presentation. And before I let Dr. Greg Ahrens introduce our speaker, I wanted to acknowledge our funding sources for this event, which are displayed right there on our board. The event was very successful, and we look forward to next steps for dissemination and implementation research. So if you are interested in being on our listserv, hearing about these events, you can contact me directly, and I will add you to that list. So thank you for being here, and I am going to ask Dr. Gregory Ahrens to introduce Dr. Raz Glasgow. Dr. Ahrens is a professor in the Department of Psychiatry and very well-known implementation science researcher in our country and internationally.
Thank you, Borshika. So welcome, everybody. It's my pleasure to introduce Russ Glasgow. I've known Russ for quite a while now. And even prior to his stint at the National Cancer Institute when he was at Kaiser, and when he took the role of Deputy Director for Implementation Science at NCI, I remember feeling like this is the right person who can really help move the field. And he is developer of the REAIM model that's used broadly for evaluation of implementation and dissemination research projects and evaluations. And the ideas that presented in REAIM really kind of helped move the field and set the stage for people to think about how we really evaluate. So in that way, he's really made contributions that have broadly influenced the field. And one of the other areas where I think he's really made an impact is on this idea of pragmatism in research and in implementation science, which he's going to talk more about in his grand rounds. But I just can't emphasize strongly enough how much that's influenced the field of implementation science in this country and internationally. So we're very fortunate to have such a creative and innovative thinker and influencer of implementation science. And with that, I want to welcome Russ.
Well, thank you very much, Greg. Am I on, Sean? How's this for everybody? Okay, volume-wise? Excellent. Well, first of all, I just want to thank the Planning Committee and Borshika in particular. We've put on a couple of these events ourselves over the last year, and I do definitely appreciate how much effort it takes, and teamwork and sweat and adapting to all sorts of surprises that go along. One of my key themes for today. I also do want to say, and I'm not just BSing you here, but I'm very impressed with the quality that I've seen. Not only the expertise of some of the people I know, the other visitors you had, but also just the students and the young faculty. And we just spent the morning going over some proposals and specific aims, and it's just consistently the level of sophistication. You guys are right on. So keep up the great work, and I hope you can use events like this to maybe further integrate what's going on. All right, well, let's get to it here. Greg hit on a couple of things that I'm going to do. I don't have any conflicts in the traditional sense. Sometimes some of the ideas I push may create some conflict, and if they do, let's hear about that. What I'd like to try and do here is present a rationale for you about the importance of pragmatic, I'm going to use D&I for dissemination implementation research throughout this talk anyway. I want to talk about how these are both similar, I should say, and different from what I call research as usual. And then I'm going to drill down on what I call the 3 M's, pragmatic models, methods, and measures. In doing this, I'm going to both try to give you what I think Greg and Borsica can check me if I'm wrong, about kind of status of the field, and as close as we come in this emerging field to some consensus. And then I'm going to try and illustrate these with some of our own work that we've done, which there's far less consensus on and that sort of thing, but to give you a concrete feel. I think that is it, other than it'll help me if you can raise your hands. I recognize a number of people, if you were part of yesterday or this morning. Could you just raise your hand so I'll get a feel? Majority, but not all. Okay, that really helps. So fasten your seatbelts, and here we go then. So why would we need this thing called pragmatic D&I research? And I'll try and explain what I mean by that as we go through. I think we all know that there's a huge crisis of failure to translate. NIH has recognized this pretty much everywhere else, and various activities such as CTSAs have been created, really, in large part to address this. I do want to emphasize two things here, though, that the most common reason for practitioners not to adopt evidence-based things, even if it's shown to be cost-effective, is they don't see it as relevant to their local settings. And then the quote at the bottom I want to give you, you've probably heard this in some form or another, about it takes 17 years for research findings to translate into practice. Well, 2 points. The first one is the last part of that sentence, and there's some convergent data. It's not just one urban myth about this on this figure, but it's 17 years for 14% of the research to translate. So 86%, nothing ever happens at all. This is like a graphic I kind of developed back and forth with Larry Green that shows some of the key points in the gap, and where there is some people talk about leakage or spillage. But frankly, folks, where we're at today, this isn't a leak or a spill, but as you can see in the back, this is a huge oil spill catastrophe, a major leak that we need to deal with. So how do we do this? I think one of the frames, again, quote Larry Green once again, is that why in the world would we even expect? The problem is, when we talk about translation, that an intervention that was studied under a very somewhat artificial, highly controlled set of conditions and circumstances and settings, with a generally real homogeneous population, why would we even expect that should or would translate into uncontrolled, very messy real-world settings? And so his quote here, he's written some great articles on, are, if we want evidence-based practice, well, we need more practice-based evidence. Another quote, I'm a big fan of quotes, but Einstein one here, probably just doing more of the same or working harder isn't going to do it. So what do we mean here? There's a whole lot of terms up here that are all related, and I'm not going to go into these unless you want to today, the differences. There's a huge amount of overlap. The point of these overlapping Venn diagrams, is there's a whole lot of things. Almost all of this is within community services, and I shouldn't even put health, the environment or population health, because there's things outside of health or that we don't normally think of. It's like clinical settings or even state health. And then they're within, decreasingly small circles, but there's a lot of overlap between dissemination, implementation. It's not the same. Today, I'm going to be focusing on this intersection of pragmatic research, but you can see some of the other evolving areas, particularly quality improvement science, which is kind of at the cutting edge of where we're going. If you want to drill down more on this, actually, Borsica is a better expert than I am on this, but I'm going to refer you to what I think is the best current reference in the field, and that's an edited book by Ross Brownson, Graham Kolditz, and Enola Proctor. Might have got the order wrong. Just out, 2018, an edited book. And Borsica and Ross have a chapter in there on terms and definitions, and all of the experts that we had here, Greg and others that have been here, also have some really nice chapters in there. So what about this different approach, pragmatic approach? This actually was developed, the main framework I'm going to talk with you about was developed not here, but in the UK and Canada. And because some terminology is different, they talk about differentiating an explanatory trial, by which we mean efficacy research or efficacy/effectiveness, to a pragmatic or a much more real world, or in some tapes demonstration, but still controlled fashion. The bottom line is the key feature of pragmatic research is a strong emphasis on generalizability. So here is a table that probably is hard to read, and I'm not going to bore you with all the details, but this sets up kind of extreme cases, or a straw person, if you will, between a completely efficacy or explanatory trial, and I've used RCTs for example, to emphasize that there are pragmatic comparative trials and comparative effectiveness studies like those funded by PCORI that do have high degrees of internal validity. I want to leave you, that's one point. Being pragmatic or doing D&I doesn't mean that it's sloppy research or it's poorly controlled or doesn't have internal validity. What it does mean is it has at least a higher degree of external validity. So again, you can just contrast some of these goals and examples, but the main one, just if we look at the top, is the primary goal of a traditional efficacy study is to determine cause and effect. And to do that, we have tight experimental controls. And that's a good thing, maybe even necessary, to establish that. In contrast, though, a pragmatic trial, is intended to inform clinical and policy decisions in very diverse settings. So we'll come back to this. In D&I in general, and also in pragmatic research, but especially in D&I, we talk a lot about the importance of models. Theories, frameworks, and models. I won't split hairs to talk about the difference, other than a theory is a much more formal thing that has clear deductive hypotheses and things. And we use these models, frameworks, and theories for several different reasons: to understand conceptually what we're doing, to plan intervention, and then to evaluate programs, and that can be policies or programs. So I am going to talk about REAIM, and let me do a quick show of hands here. How many of you are familiar with REAIM? So I'll know I don't want to bore you. Okay, well, a good number. So Borsika or somebody has brainwashed you to some extent already, I see. I will point out, though, REAIM is one framework and an offshoot of it that we use called PRISM. But on one of the best single resources that I know is a website that Borsika and colleagues created here, just disseminationimplementation.org, that reviews not only the predominant, now 91, we're going to be updating this, models and frameworks, but it also talks about how do they compare, give you some guidance on when or why might you use one versus the other, in what situation, their level of focus, how can you maybe adapt or combine models. So I'll refer you there. REAIM is one of the more commonly used models for grants and publications. The most recent sites I've seen show that it and diffusion of innovation, the classic model by Ev Rogers, have been the most commonly used for NIH applications, although that's increasingly less true. The CFR, Consolidated Framework for Implementation Research, is now used, and it totally dominates VA work and a lot of other work in terms of the leading conceptual model now. I do want to just leave you with today, though, because a lot of people get confused when they talk about D&I. They say this is overwhelming, and actually there's some good reason to believe if you consider things like more community and organizational models, Greg can probably reel off 50 organizational models himself in terms of doing that. But the point is that while there are differences, as in my previous diagram, there's a huge amount of commonalities across these models and theories. And for today, that's kind of what I'm going to, rather than splitting hairs or my model's better than your model, I'm going to try and emphasize some of the commonalities and why I think these as a group are important. So In general, I think REAIM has been fairly popular. One reason is that it's relatively intuitive, at least compared to the incredibly complex alternatives that are out there now. And it makes some intuitive sense, but we found that even with that, not even researchers can always use it or operationalize all of the elements, quote unquote, correctly. And certainly what our eventual goal was is to help this improve public or population health. And we know from a lot of experience, and we're now doing a review of public health and community settings that have tried to use it, is there's some translation problems with REAIM. So now Paul Estabrooks and I are kind of on a bent to try and push more pragmatic use of REAIM, where we're translating these, fancy terms like adoption, for example, which is technically defined as the number, percentage, and representativeness of settings that were considered appropriate and then approached and initially began program, instead of like, well, where was this applied, and who applied it? So some more common English or terms, and I'll let you know in about 5 years if we've been successful at that at all, or if it's any more user-friendly. So why might you want to use this? The end goal of REAIM hasn't changed over time, even though the model has some, and that is to help us think about what's required for a public health or a population impact. And I want to tell you a brief story. I'll ask those of you that have seen it to bear with me or check your email or something for just 2 minutes as I walk through this. But here's the story. I'd like you to imagine your own area, be it heart disease research or cancer or depression, whatever, that there was this hugely successful, I like to say, complete multi-site international triple-blind trial that just demonstrated beyond anybody's speculation or doubt that 50% of the people, had this was wiped out. Okay, whether it was cancer risk or blood glucose levels or completely cured, quote, of depression or something. We got that, but now let's walk out, and this is the headline, and we should justifiably be incredibly proud and excited about that. Now, though, let's take the scenario. What are we going to do to see that this makes a real-world difference? Well, here we have the dissemination step in the order they usually occur, and using, since we're in a med school, going to use a situation, a healthcare setting. These are the REAIM concepts. What I want you to do is watch over here what happens to this overall population impact. And the number we're starting with is the 50% that benefit totally, wiped out the problem altogether we start with. But then, it's a thought example here, where you have to get this in practice in clinics that have a lot of competing priorities, that are low resource, they have all sorts of craziness, don't have any time. If 50% of those adopted it, that impact goes down to, well, actually it should be down to 25% even if we had this here. But the point is, and I'll have to adapt this slide, is then within clinics, you only have a subset of clinicians that are early adopters, that are risk takers, willing to do that. And then you have to get to one of the more common things people associate REAIM with is the reach of the patients for whom it's appropriate. How do you reach them? So what happens when you go down here is this incredible intervention that was going to change the world. In some ways it does, but we get down to a population impact of somewhere around 1.5%. Now, again, those of you fans of Jeffrey Rose or trained in public health, that's not bad. That's probably not bad, or smoking cessation, but it's a far cry from what we might think and what you read in the paper or even the journal articles. This is just a quick slide to show you that all of these 50%, I get challenged on this, are overestimates. In the real world, look at the percentages there that you see in the left-hand column, and this is more realistic for a real effective weight loss intervention. Okay, so pop quiz for you. What's the moral of this story, of the diagrams that you saw here? We can use that one if you want to look at it a little bit more. What do you take home? What's the take-home message? I'm not going to go on until you answer. Well said, probably better and more pragmatic than I would. You got to open up the bottleneck or think about this. One other response? Anybody? Or at least equally important, exactly. And again, that's the science of implementation science, is to look at the how. Evidence-based medicine usually focus predominantly on the what that's done there. So what are the implementation strategies and how do you make this happen? I think those are both great, probably as good as mine, but I want to emphasize that there's optimism here too. Usually people get really depressed when they see that. They say, oh my God, my life's work, I'll just give up and switch to another field or go back. But at the same time, if you look at all of those points in there, each one of those is an opportunity to improve what we do, and in every case, it's received far, far less attention than has the effectiveness dimension. I want to stress, I'm not here to say we shouldn't do effectiveness research. We definitely do. We need that. That's in many ways where often, not always, but implementation science starts. But we can't stop there. It's necessary, but not sufficient. And each of those is an opportunity. And then I like to say the other quip is it's about the denominator. Because whether it's patient level, like patients that come to a weight loss program, okay, or at a setting level where what do? We take our networks of, cancer centers that we have, the best cancer centers in the country. That's good, that's important, and that's really great work to start with, but if it also doesn't work in community centers or that sort of thing, it's at least limited in terms of its impact. All right, so I'm going to quickly summarize about 18 years now of re-aim, and where has it gone? There are a number of reviews, the two at the bottom I'll refer you to, and slides will be made available. It's been grateful to see that it has been applied to a whole lot of different content areas, not specific to health, but different problems, and used a moderate amount internationally, particularly in Europe. I do want to stress one point, and we can come back to this, but we argue, and we do have at least 2 or 3 publications showing that re-aim can be used effectively for planning as well as evaluation. You might want to cite those articles if you want to use re-aim or a PRISM, because we've seen reviewers beat you up for this, saying you're going to use re-aim for planning. But it has been done. It's used predominantly for evaluation, and historically it's been used predominantly for post hoc evaluation. We're now trying to change, make the model a little more adaptive and able to use throughout the phases, throughout the planning, implementation, and summative evaluation or review. We do know, like most models, it's been incompletely, even by researchers, implemented, and they're underreporting of some key components, particularly adoption, and as you might imagine, sustainability are reported the least often there. Some areas that we're going now is number one, and this should be, and I think probably is, the focus of almost every meeting on implementation science or D&I, is context, context, context. We have a particular way that we're trying to focus on elements, but of which elements of context, because there are thousands or millions of things you could focus on, and we have different meanings by that. There's a lot of conceptual work and brought in from different fields on context, different measures. In my estimation, we probably today are still at the point where we need mixed methods. I don't know, with maybe a couple exceptions, that there's one perfect survey that's done or one that you're going to get everything you need in a focus group or something like that. But that's one thing we're working on. Cost, I'm going to come back to, so I won't say that, but I think this is a huge underreported area, and frankly, if we want to contribute to learning healthcare systems and get things adopted, if we can't address that question of showing its values, its cost effectiveness, we're kind of dead in the water there. Adaptations, we've been talking a lot about the last couple days, and that's a key part of, under re-aim, we put it under implementation. How is the intervention and or the implementation strategy adapted? Last one I'll mention is, particularly since Allison is here with us today, more qualitative approaches to re-aim to kind of get that mixed methods interface we need. So in summary, REAIM is an outcomes framework. It can be used both planning, evaluation, and I'd even argue, being a little grandiose and having a tiny amount of experience at our med school, all the way from T2 to T4. I haven't really figured out how to do it in T1 yet, although I do have one little anecdote story that if you wonder, I can tell you about offline. Again, each dimension is an opportunity. REAIM can be used to inform what we're doing in observational studies or maybe even modeling studies, as well as more traditional interventions. And I think I will go on from there, other than to say I always like to remind myself, because Greg was overly generous in terms of the impact REAIM has had. I do think it's had some, but we're still learning. It's a work in progress, and frankly, I think given the status of the field and what we find, it really have a little too much hubris or be hypocritical to say that it's fixed or it explains everything and stuff like that. So we are continuing to work on it. What I'd like to do next is just talk about a couple pragmatic design issues, and then I'm going to pause for some interaction. I don't want to wait to just put you all to sleep and then talk about it. This is my homage to the royal baby here. Calm and be pragmatic. We're not going to talk today about, but in terms of design, there are all sorts of pragmatic designs, some of which are just minor offshoots of the traditional RCT, but certainly cluster randomized designs and the step wedge design have been two of the leading approaches within D&I that have done that. But there are also some others, and sometimes they're a little more interesting and innovative, like a preference design where choice or shared decision-making is important. We can learn a tremendous amount from natural experiments, particularly in cases like policy, where at least to my knowledge, most states aren't willing to be randomized to like a policy for healthcare coverage or like opioid approaches or something like that. I like this figure, I adapted from Gloria Coronado to kind of do a visual of how a traditional RCT and a pragmatic RCT may differ in terms of a funnel. And the notion is here in a traditional RCT, we start with, well, first of all, we have an eligible population, and the first step isn't shown here, is usually in a traditional RCT, we dramatically reduce who's eligible, because we don't want to have things that mess it up. For example, the classic ones, if you're studying diabetes, you get rid of people that already have hypertension or heart disease or depression or something like that. But then it goes through this funnel, and I want to emphasize the funnel takes place at the population and the setting and the staff level as to what types of settings do we do this. And again, when we get an efficacy study down here to a defined subset, this is important, and this is where you really get the experimental control and you can really try and address cause and effect. Contrast that with the pragmatic trial, though, which has a much broader funnel. It actually has, more than this. But again, the percentage and the representativeness of the settings and the population and the staff get progressively broader. And so at the bottom, you have a lot more. Quick question while I catch my breath. How many of you are familiar with, this has different pronunciations. For the Francophiles among here, including myself, it's précis. And for others, it's called precise, which is interesting. But how many of you have heard of this framework or this notion? For it's related to pragmatic research. Okay, not too many, so I'm going to spend a little bit more time. This is a model. It was developed by some of our Canadian and European colleagues, shown here at the bottom. The current definitive reference, there's been a revision, is by Christy Loudon and colleagues. It's called Précis 2. There has been a revision or an update already in it. But the point is, it takes 9 dimensions I'm going to show you in a moment, and it talks about to what extent is a study And originally it was designed to be used in planning studies, and I think it's still most broadly used there. But we've also argued an article by Bridget Gaglio and colleagues and demonstrated that it's also quite useful for both reporting a study and doing literature reviews also. And I'll show you one example of that. The notion behind it is that table I showed you before. That really is kind of a straw person example or extreme case. In the real world, no study is absolutely 100% pragmatic or 100% efficacy study. What you do is you need to make a number of important decisions that are based on the state of the science, the presenting problem that you have, the interest of your team, who your stakeholder partners are, and that sort of thing, where you decide in what dimensions is a study going to be more pragmatic and in what dimensions is it going to be more efficacious. So here is the infamous wheel, or the diagram. I think this is really pretty nifty. I like visual displays that summarize things succinctly, even though I'm not good at them myself. But this one, what it shows here is a wheel, and it ranges from either 1 to 5, or some people say 0 to 4. And what you do is the further out you get on a dimension, this is eligibility. And the question you always ask is, how similar is this to usual care, or settings that we're going to roll this out to, okay, to produce a public health impact? How similar is this to usual care versus an artificial lab environment? The more the answer is yes, very, very similar, you get a 5. So you put a point here. If it's very efficacious, huge selection, that sort of thing, you'd get a 1. Then what you do is you connect the dots. You answer each of these questions, things like the primary outcome. Is it patient-centered? Is it one single biological outcome? Adherence issues here and flexibility are a big one. How much flexibility is there, both in terms of what the patients do, what the delivery agents do, while the settings are able to adapt it or not? And so you connect the dots here, and you get a little diagram. Instead of saying, well, I have a hugely pragmatic study, trust me, or this, or it's a mix, you kind of show people, show them your work. And I strongly encourage all of my mentees and colleagues to put this in the grant. It's still not that widely used, but I think it just conveys a whole lot, even more than a usual figure or table. And so you see what we found here. We use this to review a number of e-health interventions, and we found that there was really a mix. Most of the studies were moderately pragmatic. In some ways, a little more pragmatic, like issues on practitioner adherence or the platform, the primary analysis. In other areas, they were a little less pragmatic here. What I didn't show you, and I'm going to change this slide when I get back to, because I haven't used it for a while, is I should have shown the confidence interval around that, because of course it's huge, and in that case that's probably more informative than the mean or the median that you see here. One more thing on pragmatic, and then I'm going to let you have at it and talk at me a little bit, is we took one other shot at something that might translate to folks in terms of making research, both D&I, but it doesn't have to be D&I research, more pragmatic. And this is what we call our 5 R's model to increase the likelihood of translation. And I partnered up with a number of my family medicine colleagues where I now live, particular CJ Peak, who's a great thought leader, and my chair, Frank Degree, to talk about this model, to try and, the goal is to try and design studies that are relevant. Remember, that's the number one reason things aren't adopted, that are rapid and recursive. Allison Hamilton is a key leader in the field. I think this is one of the maybe 2 most important things that we need to do that we don't do now. It redefines rigor, or it broadens rigor to also include external validity, not just internal. It reports resources required, and in case you don't know what mumbo jumbo that is, It just means cost, but cost didn't start with an R, so we had to make up something there, reports resources required. And then the bottom line, and I think is a huge science issue, not just for D&I, but in general, is replicable. And if we have time, I'll get in and talk with you a little bit more about that and how I think D&I can help address some issues of replication through transparency in reporting. But just for now, the cost issue here. I think costs are a little different from a D&I perspective, and that cost has to do with issues from the perspective of multiple or different stakeholders here. Cost, in my world, aren't solely financial dollar cost, but they're also costs like of time, of burden, of issues like opportunity costs that are there, and they differ depending on the perspective of stakeholders. I particularly like and have been fortunate to interact with a great health economist colleague, Deb Ritzwaller, on working on something called the replication cost of an intervention. And the notion there is, in addition, you do the usual cost analysis or cost-effective analysis that you want in your study as you did it. But frankly, that's not the thing that's really important, or that what somebody in a different setting wants to know. What they want to know is, what's it going to cost me in my setting? I don't really care that much about your research. So Deb has developed some formulas and algorithms where you can talk about, well, let's look at your setting. What are your staffing patterns? What are your resources? Do you have an electronic health record that's interactive or not? And then what would it cost to replicate this in different settings? These are estimates, of course, and you do sensitivity analysis around them, but I think they're tremendously informative. Okay. So I'm going to take a breath before I go through a rapid-fire example of one pragmatic D&I study. But let me just go back here, and I'd like to take at least a couple questions or comments. And anybody that's totally offended, you can leave right now. Do this, but see, Greg? Oh, Elena? Go ahead. Yeah.
Okay, thank you. So I'm fascinated by that tool that you assess the degree of pragmaticness. I don't think that's even a word, but anyway, what if I feel that I have a really good pragmatic trial, and then I go through this and I come up with your next slide that's only like mediocre?
Yep.
When can I call it a pragmatic trial?
You know, I don't think, it's a good question. Did you all hear it? When do I call it pragmatic? A couple of answers. The first one, I think part of this is to break that dichotomy out there. And in a minute, I'll give you another answer, and then see maybe Ethan from Picori has an answer, because they're funding pragmatic trials. But to me, any trial is more or less pragmatic, you know, when you do that there. I suppose if you're getting consistently 3s or 4s like that, then you could say that trial is more pragmatic, okay? I will give you a concrete example in just a moment when we go through this My Own Health Report project. So Ethan, do you want to respond to that, or?
You know, all I'll say is I think it really depends on where in these dimensions you're up or down, right? Because it's going to really depend on your particular study.
Yeah, I think it may also depend on, now you bought me some time, so I maybe have a better answer now, so thank you. It may depend on where the field is and the prior research. If the prior research has all been number 1, then it's probably a contribution. Maybe you don't want to go all the way to 5 on the dimension. Maybe you only want to go to 3. Greg?
Yeah, so you talked about the estimating costs of behavioral interventions, and I wonder if you could say a few things on work of on cost of implementation. So Lisa Saldana has the coins, the cost of implementing new strategies.
Yes.
As another piece that would be of, I think, great interest to service systems and hospital systems as well.
Absolutely, thank you. In Greg's nuanced question there, we talked about interventions, and it's important in the field, for those of you that aren't familiar with it, to differentiate the intervention per se, the components, the what, from the how, or the implementation strategies, which also have a lot of cost and a lot of issues and things. I think this can be used to do that. In my areas that I play, to be real honest with you, in primary care, they're often blurred. And even in a query study that Borsuk and I are working on, I don't think I'm speaking too much out of turn, particularly talking to the clinicians, it's sometimes a tough thing to differentiate them, but they are. But for example, audit and feedback is one of the more frequently used implementation strategies. There are cost, and there's also, though, it isn't just one overall cost, because it depends on what types of audit and what types of feedback, using what data and what systems, and who gets the feedback, and how much training do you provide them, and that sort of thing. So I do think it's an important issue too, and it's a third slide I'll revise when I get here to have implementation cost as well when I get there. One strategy Borsuk mentioned quickly that came up in one of the groups, but not all, again in partnership with Deb Ritzwaller and some colleagues, is we have our own little variant or offshoot of a way to address the cost, and I think it might work for implementation strategies as well as interventions, and that's called a minimal intervention or maybe a minimal implementation strategy needed for change. And the notion behind this is it's a different type of control. Rather than using a comparison condition that's just usual care, and we can talk more about that, the pros and cons. For a CER type study, what we recommend is from your knowledge of the literature, your personal experience and things, one of the, if you will, intervention implementation plans should be to do the bare minimum of what you think. Some of you had some good examples. You didn't call that the last day or two. That might be like you develop a really great web-based resource, okay? And they could maybe do online training and do that. There's some reason to believe that that's well done, user-centered design, consistent with the literature, consistent with theoretical principles. That might work, or at least for some of the people, some of the time. Probably, in order for people to really use it, though, you're going to need some training, some supervision, some mentoring, some ongoing feedback. So I think a neat design is to kind of have this minimum one, and it's not just a traditional, like a placebo control. You think it could work, okay, but it's minimal cost, actually, using this with a much more intensive design, and then the primary outcome actually is cost effectiveness. It's not just effective. The more intensive one is probably going to be more effective, but it's probably going to have in re-aim a lower reach too. And so then kind of the trade-offs and cost effectiveness. So how about one more question here, and then I do have a few more things I want to cover. Yes? Right. Yeah, great question. I have at least three answers. One is re-aim itself is really used to measure the impact of that. Policies in general are one of the best ways of getting that public health impact for the reasons you just talked about, and others, and particularly to get sustained effects and sustained maintenance and broad population reach, assuming that the policy is well implemented and consistently implemented. Second answer is, and I cut this out, Borsuk made me, I had a 3-hour talk for you and Borsuk made me cut it down, is I said we're focusing on context and now with re-aim, and so we've made this extension or expansion that we call PRISM, that I won't bore you with, but it adds some key contextual factors to it of the external environment and what we call the infrastructure system, and that would be a good example when you have a policy in place there or incentives or something, or another classic one to do that. But it's critically important, and I think the other thing for the field that's fun to think about, and we did a little bit, dating myself in the old days and smoking cessation before we had clean indoor air policies and before we had taxes and increased taxes and things. And I think looking for the sweet spot about how you can use policy to create an opportunity where you're going to have much greater organizational and personal readiness, and looking at the two when they fit there, and some great state level experiments going on, when the states did different levels of things. And in fact, I think that's one of the issues that has come up the last couple days, is for sustainability, designing an intervention that's going to fit within policy, within reimbursement, be reimbursable. Today in our healthcare settings, often if it doesn't have some way of interfacing with the EHR, it's a deal killer there. But I do like, again, gave me another chance to use another quote, the Wayne Gretzky quote. For those of you that don't know, like world famous hockey star, they asked him, Wayne, how are you so great at doing this? And he says, I don't skate where the puck is. Those of you that had kids, it's all this nest around right where the puck is. He says, I skate to where the puck's going to be. And that's the thing about anticipating policy and other upcoming events. And I think if we want to design for the future, not only for dissemination and sustainability, we need to think, what's the new environment going to be, not today, but 5 years from now when our study's done. Okay, let me go ahead and do one more thing, and then I'll give you a choice what you want to do in the rest of our remaining time here. I'm going to just quickly rip through this as a concrete example. I'm going to argue this is both an example of pragmatic research and of a re-aim application. It's what we call the MORE study. You can see it. What it is it's an online web-based health risk appraisal, assessment, and feedback, real-time feedback system that it's in the public domain, and it gives immediate feedback to both patients and families and a healthcare team. Note the outcomes here were implementation outcomes. They weren't necessarily, well, we have one we call effectiveness, but I'll, spoiler alert, what we meant by effectiveness was this consistently used to establish a goal, a shared goal between patients and providers? The focus was primary care, predominantly FQHCs, community health centers. We went, instead of cherry picking the very best ones, we picked the most challenging ones. English and Spanish, a lot of border communities in Texas, huge low literacy populations, that sort of thing. So we were gluttons for punishment on this study. So here is, I know you can't see that, but the little feedback form that's produced immediately. And all I want to emphasize is that, again, being gluttons for punishment, but thinking about primary care. I've done a lot of work in smoking cessation. Many of you have done great work on physical activity. Okay, others have done, colleagues, great work on healthy eating, nutrition. Depression is a huge area in primary care right now. The primary care physician doesn't have the luxury of just working on one thing. They are responsible for all this entire plethora of things. So we took, I believe it was 9, I forgot the count, different things all the way and did a real rapid screening. This is not necessarily diagnostic, but a rapid screening about all of these things. From fast food intake, we did sleep, physical activity, alcohol, tobacco use, then some, quote, behavioral health things, stress, anxiety, and depression here. Provided feedback here, and then what you can't see here, after you get the feedback, in preparation for your visit with your healthcare team, the patient checked, one, were they ready to change? Then we did have some little interaction to help them answer that question on each of these. And then second, which of those did they want to discuss today? One interesting little anecdote that I won't go into other than a sentence is we pilot tested this and did at least a modest amount of stakeholder-based feedback, and we found those two things are different. I would have thought that they really would have been the same, that if you're ready to change, you want to talk about it today, but that's not necessarily the case, and there's kind of discrepancies in both ways there. Okay, so here's the results. That's what it is. So adoption, that's the first thing, clinics. We approached, again, we took 30 practices, and again, these were very challenged. It weren't practices we'd worked with before in the past and were our buds or had the best electronic health record. We got 60% adoption rate. And we had 9 sites. I should have said this. The evaluation was a cluster randomized trial, 9 pairs. So in each region, there was a pair that was randomized to, cluster randomized to clinic to intervention versus control. So 7 of them participated, and again, we got a pretty broad spectrum, and on the lousy measures, we had no differences between those that participated and those that didn't. So the reach is really complicated, but bottom line, about half of all the possible patients participated. So these weren't ones that were consented to research. These were all the patients that had an upcoming primary care visit during this, or some sites restricted to like an annual exam to come up, and they did do some exclusions, the funnel. The point here is that we had interesting experiments, and we allowed a lot of adaptation and customization. And so they had the exact same program. They used the kind of generally the same content for recruiting, but they had quite different implementation strategies to do their recruitment. Some of them mailed, did the more traditional. Others approached the patient in the lobby or the waiting room where they're doing it. Some others had somebody like an MA or I think one case a peer navigator approach people. The most successful one actually, I take it back. The most cost-effective one was actually have someone call. And we didn't come up with this. We gave kind of a menu, and the sites chose which way they wanted to do it to fit their setting. So implementation strategy, again, we're focusing on how did they get this done. It was the same program, okay, the same web-based program, the same feedback, but how did they get it done? And you can see there are different implementation strategies for doing it. We did do one thing, trying to look at our cost, that was kind of depressing, but if you think about it, not too surprising, that from bottom to end, if you truly costed everything from the recruitment, okay, to the assessment, to supervising that, to getting the feedback, to acting on the feedback, okay, it took an average of 28 minutes, which frankly, for most primary care is a non-starter. Okay, so in order to do this, the ones that are most effective had a handoff. So it wasn't the provider himself, but like a behavioral health or somebody else like that. There again was a fair amount of variability around that. Our primary outcome, a priori specified, was did you set a goal or not? And you see that's broken down here by the 9 different target behaviors. And in general, except for the ones that had a real low prevalence at baseline, kind of a Bayesian thing, we did show increased probability of goal setting. We had one measure to push our luck a little bit, and this was all self-report measures. These were generally considered some of the best brief measures, pragmatic measures of self-report, patient-reported outcomes, but they were short-term and they were self-reported. But again, you see, we did see some effects there. So what I'd like to argue or convince you to try and pull this back is that, in fact, this is a pragmatic study. And if I had the diagram, Elena, which I should have, showing you how our rating, they would have been generally 4s or 5s with 1 or 2 exceptions that we had on there. But I'll let you read this, but this is how we argue that we felt that it was rigorous, rapid. From a science perspective, I will argue that I think it was more innovative or cost-effective than it probably was from a strategy itself. This was all done with 1 year with only supplemental funds in 9 sites, 18 cluster randomized clinics with stakeholder involvement, did the intervention, did some of the analysis in a little over one year. So in that way, I think it was an example of more rapid. I think it was transparent in that we have reported on our failures. I didn't emphasize them today, but one of them was the cost issue. And I should say the fact that, although not a surprise, there was like only 1 clinic continued something afterwards. So our maintenance was like, 1 out of 18 or something like that. So it was minimal. I think there are good reasons for that. I'm just going to do this so we can have some questions in the last few minutes. The moral of this one, I won't quiz you, I think, is that you can be successful when doing even a minimal intervention here, can have high reach, at least produce some results, high levels of adoption, but it depends on customization. And it depends on customization at multiple levels. Level number one, the patient. Okay, choose how to do it, family. They can decide how they want to do it, the clinician and the setting there. And finally, I guess where we're going, some of the future contributions there are we're going to try and integrate this better into the electronic health record, and as we talked about in a small group today, combine this with big data that's commonly available in the biologic data and the utilization data, the pharmacy data that's often available. We're now working to adapt it more 2.0 or 2.1 to incorporate social determinants of health, and then a much more ability to customize the entire thing, including what the content is to different settings. So let's have some general questions here. I think I'm gonna, as we're talking, skim through my remaining slides, but let's take it, the few minutes we have left, take some of your questions. This is a slide I stole from Borsica. I don't know if you made it up or if you stole it from somewhere. You stole it too. Okay, that's great. So any lawsuits, talk to her, not me, but the proverbial forest and the trees. And let's have some more interaction and questions. Yes?
Thanks for your talk. We heard a lot yesterday about meaningful stakeholder engagement, and I think anyone who's done this work knows how much time and effort that takes. As someone sort of starting out my research career, it seems like there's not necessarily incentives in academic research for that time.
Yep.
I wonder if you could give some reflection about how to reconcile that.
Yes and no. Yes, you're absolutely right, and no, I don't know. Places are starting to do it. A few places are starting as maybe a little more broadly in terms of CBPR and things, giving credit for as a type of community service or engagement or whatever, looking at that. It does take time. I think one of the cutting edge opportunities might be in this area as well as many others, and not everybody agrees with me on this, so I'm kind of shooting my mouth off here, I think we actually can cut down the time that it takes. In a couple of ways I think we can do that, although I can't prove it to you, is one, we talked about it, is more purposive sampling of who it is that we interact with the stakeholders. So we go out, we make sure we get the diversity of the types of people rather than just doing a, quote, convenience sample or random. I think some of the new things that we're learning and approaches in digital health and engineering and things and some of the design, the user-centered design or co-design lab, we can do more intensive, even though it's not with a huge number of people, and rapidly iterate the interventions. Then that's an important type of stakeholder engagement. Myself, I prefer to have stakeholder engagement. Well, I shouldn't say it's not a forced choice, but I probably put more emphasis on kind of the middle ground iteration than I do initially. I think often we know, if we're in touch with our settings, kind of what are the big issues out there. Like in primary care, I know it's always cost and competing demand and that sort of thing. So we get some there, but then where the engagement is in this rapid iteration is around a prototype of the intervention itself. So, sorry to be so long-winded. I'm going to go ahead while we're talking here. Borsica, I'll just let you cut it when we're done with time here.
One more minute. Any other questions?
Well, well, I didn't get to this. What's my current soapbox? You can see what it is or talk afterwards. I don't know if we need to vacate the room or not. I have a little time. But I'm going to leave you then with what I call the bottom line question of pragmatic research. And the notion is here, again, this issue of replicability that we didn't get a chance to talk about. I think that maybe from a science perspective is the bottom line. But I like to focus on what I call the ultimate use question, which is an aspirational goal. It's probably not possible in any one study. And we like to say with REAIM, we like to have people think about this. We do think pragmatically it may be possible in a number of settings with judicious use of low-cost assessments to assess most of these issues in blue. It's probably not possible, nor would you necessarily want to try and intervene on all of these issues in a single given study. But if you think of a program of research, this is the body, like for your K awards over the next 5 years, okay, you can answer in your area this question. What are the components, the intervention, the what, most effective for what outcomes? I want to say that's critically important, what outcomes? For which populations? Oh my God, I didn't have, oh wait, no, I don't have implementation strategies explicitly here. Man, you really got a poor speaker here today. So should be what implementation strategies, when implemented by what types of person, under what setting and conditions, how many resources, and then importantly, how and why does this come about? So thank you very much.